Just it's just coming up on 5 o'clock, so I thought we would go ahead and get started. We've got with us today Dr. David Yeager and Dr. Jeff Mcallister as our panelists and our presenters. But before we jump into the case presentations, what I'd like to do is just take a quick walk through some of the Nanobone technology to give a little bit of background on how we got to this point with Nanobone. I'm Paul Byerley, by way of introduction. I'm the CEO of Artoss and one of the co-founders of Artoss Inc. here in the US. So launching into this, let me see here. There we go. Nanobone synthetic bone graft is a clinically proven cost-effective replacement for all other bone graft materials. The Nanobone SBX putty, which you can see comes in a variety of different sizes in the syringe, uses what we call applied nanobiology for bone repair. And what we're talking about is we are unique in the size of the material that we use, and that we use nanoparticulates as a foundation for Nanobone. The Nanobone SBX putty is indicated for use as a standalone bone void filler. It's actually a bone graft substitute, which is a little higher standard for synthetic bone grafts. It actually is designed to be used as a standalone, as you don't really need to add anything to it to make it work. So you don't have to add blood or bone marrow aspirate or any other material, even in spinal fusion, one of the more difficult places to get bone to grow. The QD is an iteration of the applicator, in that within the QD, it's preloaded, and QD stands for quick delivery. It's preloaded with 5 cc's of the Nanobone SBX putty, and it allows for precise and rapid placement of the bone graft into the surgical site. So when we talk about nanobiology and really sort of the embodiment of what Nanobone, the foundation of Nanobone from a science perspective, what we're talking about is really the foundation, which is the hydroxyapatite, nanocrystals of hydroxyapatite. And what we've done is we've got nanocrystalline particles, 3 nanometers thick by 50 nanometers across, suspended in a silica gel matrix. And that's the combination of those two, the HA and the ASG, gives us Nanobone. The hydroxyapatite nanocrystals have a similar size and shape. We actually call them bioidentical. So they're the same chemistry, morphology, and size as what's naturally occurring in human bone, which is the 3 nanometer by 50 nanometer tiny little particles. And to put that into perspective, 3 nanometers thick, which is the thickness of each of our crystals, is thinner than a strand of DNA. So it's very tiny stuff. These nanocrystals aren't bound together. They're suspended in the amorphous silica gel as the composite. Essentially, then you can see in the slide, the ASG allows us to form a matrix between the HA and silica gel, and that allows you to have a granule that you can work with. The ASG is not inert. It's got some biological activity of its own. So it's very hydrophilic, and it releases silicon dioxide. And so there's a negative charge associated with the ASG, which triggers angiogenesis and actually helps to start forming a clot right away. The negative charge actually kicks off what's called clotting factor number 12, or the Hageman factor. So that's the very first thing that happens when you implant Nanobone in situ. To give a little bit of a sort of a graphical representation of what I'm talking about, you can see, if you could get ultra magnification of one of our particles, the blue in the little picture to the left represents the amorphous silica gel with those 3 nanometer by 50 nanometer wafers suspended in the ASG. On the right, we form granules out of that material that you can handle. Those are roughly 2 millimeters by about 0.6 millimeters in size. They kind of look like little pine cones. To make the SBX putty, what we do is then we add an inert carrier to that to make that product handle well, so it's cohesive. It's not just a bunch of loose granules. What happens when you implant Nanobone is the ASG is replaced by organics. So it's all the different proteins that grow bone. So you've got osteopontin and calcin and all the different BMPs and fibronectin and vitronectin. There's a whole slew of different proteins that essentially kickstart bone growth. And what happens is those proteins actually stick with a higher affinity to the nanocrystalline HA than the silica gel does. So those proteins come in and then selectively replace all that silica gel, just basically pushing it out, and then that is then excreted out of the body, leaving those nanocrystal particles in place in a matrix now of just organics, all the different proteins that you need. You're going to have early blood supply, you're going to have cells, all the stuff you need to grow bone. So that happens in about between 10 and 14 days post-implantation. So by 14 days, essentially all the ASG is gone, leaving behind an organic matrix that has the nanocrystal particles of hydroxyapatite. So effectively what you wind up with in just a 2-week time frame is an osteoid formed, but it's a little bit more than that because osteoids are not typically mineralized. We have a mineral component to our osteoid at 14 days. No other product on the market does this. This is a unique mechanism of action to Nanobone, and that's what, quite frankly, is the foundation of the success, the clinical success of the product. Here's a few slides that show that you're attracting now all these different growth factors and different proteins that help to grow bone: osteocalcin, osteopontin, BMP, so on. At this point, what I would like to do is introduce our first presenter, Dr. David Yeager. Dr. Yeager currently practices at Morrison Community Hospital in Morrison, Illinois. He graduated from Seattle University with dual degrees in general science and English, and graduated from the honors program. He is a doctorate graduate of Rosalind Franklin Chicago Medical School at Finch University, where he received his doctorate in podiatric medicine. He graduated residency from Cambridge Health Alliance, which is affiliated with Harvard Medical School. He is dual board certified by the American Board of Podiatric Surgery in Foot and Reconstructive Rear Foot Ankle Surgery. He is past chair of the American Society of Podiatric Surgeons, where he is the current education chair. He is also a fellow of the American College of Foot and Ankle Surgeons. He is a past board member of the American Podiatric Medical Association and past president of the Illinois Podiatric Medical Association. He is a past residency director and actively promotes education or educating the young physicians of the podiatric profession. He has several publications and recently was guest editor for Foot and Ankle Quarterly and has performed several research projects. He has lectured both nationally and internationally on a wide range of topics, from wound care to advanced foot and ankle reconstruction. He has volunteered locally and nationally for several organizations and is honored and privileged to lecture at this year's Midwest Podiatric Conference. Thank you, Dr. Yeager. Go ahead and take it away. I'll flip to your first slide.
Thanks, Paul. I appreciate it, and thanks for those kind words. It's just want to thank you all for taking time out of your families, your practice, and whatever you might be doing. And these are incredible times in which we live in today, and hope you and your families, wherever you are, wherever you may be watching this presentation this evening, are staying safe. So when Mr. Byerley contacted Dr. McAlister and myself, really wanted to talk about case studies in the foot and ankle arena. I know that this is a new arena for them to get into, and it's unexplored. However, it is an incredibly emerging specialty. And, like any other bone graft, I was skeptical. I wanted to be proven. I don't know how many times I've had bone graft go in and bone graft go out. If you all know what I mean, you squeeze it and it comes out. And it's very disappointing. The patient freaks out. And I was very skeptical. However, I have not had this experience with this product. And really, if I could stress one thing this evening, is that it's a product that you want to use on your patients if you think that they're smokers, because they all lie, okay? If you think that they're diabetic, if you think that there's something that is going to prevent you from getting and healing what you want to be and where you want to end with the patient. And so, in a nutshell, the three cases that I have this evening, and I'd like to just jump into them, is cases that, number one, are number failure, or number two, patients that I think are not going to heal. So we can go back one slide there real fast. I'm sorry, Paul. Yeah. So 65-year-old smoking female, collapsing Pennsylvania valgus deformity, equinus, hemorrhageal deformity, right foot. The standard attempted orthotics, bracing, steroid. Second opinion, I get a lot of those, and I tell patients, hey, this is what it is. This is what I would do. And if you want to come back, great. I don't steal patients. So she presented when I opened the door. She goes, "Oh yeah." And so, I'm vertically challenged. I'm very short. I'm not very short, but yeah, I'm pretty short. Okay. And she's like, "When's the doctor coming in?" I'm like, "Well, height has nothing to do with my capabilities of doing your surgery. I have to lower the table. Okay, I get it, right? Okay." So she's like, "Okay." So it's one of those type of patients. So I'm like, "Okay, brace yourself," right? She's like, "I'm tired of monkeying around. I've seen a couple other people. This is what they want to do. What can you do?" And I'm like, "Okay, hey, I like it." So this type of conversation we all have had these in these type of patients. So she opted for surgical correction after reviewing everything she's done. Ankle x-rays were really negative for any type of deformity. So we can go to the next slide and see really where her deformity, TN, okay. Not too bad. The bunion itself on the right-hand picture is kind of, okay. But her real problem was that hammer toe and the real pain along the TN joint. So next slide, please. So we decided to do Coots with the TN joint and MIS bunion with an Aiken and fuse that hammer toe. And it's interesting because I was able to actually take some of the graft, obviously utilize it within the TN joint there, and I use it as a little bit of a spackle also on the MIS bunion too as well. Once I get good fusion across that area, it's adjunctive. Okay. And I look at the different types of hardware that are out there on the market, and there's a multitude that are out there. But there's not 100% really, you're okay. I got a little bit of a deficit there. What am I going to do? Okay. So I'll utilize it. I'll put it in, then I'll put my fixation in, and then I'll really, really cramp that fixation down to get good fusion across that osteotomy site or that fusion site. Next slide, please. So you can see with the red arrow, because, not that you can see that the TN for all of you out there, but you can see then this is actually at 4 weeks. And I'm glad that you introduced some of the background information, Paul, regarding how effective in 14 days that we're really actually starting to see this. This is 4 weeks, okay? I have the patient walking. I'm a big believer in getting patients walking as soon as possible. That's why I'm going to use everything that I can to actually get these patients back sooner. Too many times I've had these patients come in that got a little bit of, calf pain. Well, too many times DVTs are not diagnosed and can be catastrophic, obviously. So I get patients walking. If I can use something that's going to fuse it faster, and here you see in 4 weeks, you can also already see the consolidation across the TN joint there too as well. For any residents that are out there, the most common place that you're going to have a non-union is laterally on that TN joint. So make sure you guys identify that and get over there and put some graft over there as well. You can see the lateral now that the lateral looks much more improved. I prefer to use 2 screws in the calcaneus for no rotational problems. And this patient's walking. Next slide, please. Case number 2, smoking, diabetic. You can see that there's a pattern forming here, you guys. And really, I'm going to utilize something that's adjunctive. Okay, this is the guy that came to me. Had 2 previous surgeries, symptomatic hardware, outside institutions, presented to me. Actually, I should say he was scheduled at an outside institution other than the previous 2, came to me and said, "What do you got?" Okay. And anytime that you hear this in that line that says he wants the hardware, and I was like, "Oh, okay, you want the hardware to show your friends the fractured hardware?" He goes, "No, I've already have an attorney and he wants to see the hardware." So I said, "Well, I'm gonna tell you this right now on the front end. I'm not going down that route. I go, I'll fix this, but if you want me to do anything like that, I'm not going to do that. I believe in karma, and I believe that anything can happen in surgery. So I'm going to stack the deck as best as I can to make sure that you fuse." And he's like, "Okay, that's fair enough." Smoker, he's on oxygen. I just saw him this week for some final x-rays. Not the best candidate, not the most compliant candidate. We all have these patients in our offices. So he came in, he wants to, of course, refuse the joint. He also wants to fix the second and third digits and hammer toe as well. Next slide, please. So here's the preoperative images. Put the red arrow there so you guys can't see the fractured hardware. Obviously you can. He was told by a surgeon that, I've never seen this happen before. And I'm like, well, then that surgeon doesn't do a lot of surgery, right? So hardware's fractured. You know, he wants the hardware post-operatively. Fine, that's okay. So looking at this, okay, we've got a smoker. He's slightly overweight, which we all are. He's a diabetic. His A1C was about 7. Okay, we'll take it. Non-compliant, walked all over his cast. Okay, fine, knock yourself out. I'm going to use something that is actually going to stack the cards, like I said, in my favor to fuse him, because he's really not the most pleasant patient in the world, but he needs help and he's tired of getting, inferior care and having this hardware break. Next slide, please. So medial post-op, definitely bone graft worthy because of his protoplasm. And you can see though, I mean, put a longer plate in there. If he breaks that plate, I'll be shocked. But what I most importantly want to stress is if he breaks through there, it's not going to happen on my shift. All right. And so we're going to pack that. We're going to utilize some bone graft itself. I'm going to utilize anything that I can. And you can see the lateral there. We got a pretty good compression across the osteotomy site there, or excuse me, the fusion site. Next slide, please. 4 weeks. He's been walking on it. You know, I put him in a cam walker boot at 2 weeks because he just walked and destroyed the cast. He lives by himself, sits in his recliner and watches TV all the time and drinks his 2 bottles of Mountain Dew a day. So it was one of those things where I was like, okay, let's use something that's going to stack it for us. So you can see there's fusion across there. He's happy as a clam. Fusion is not broken. Just saw him for, I think, his 12-week appointment this week. So he's completely fine. Next slide, please. All right, so case number 3, previous surgery on the contralateral side by an outside institution, presented to me saying, I just don't heal well. And you love to hear that, okay? And this lady's 58 years old. She smokes occasionally, okay? So how do you know when smokers are lying? Their lips are moving, right? I mean, I don't know how many times I've talked to these patients and they say, well, how many cigarettes do you smoke? What inevitably they say? 3, right? They always say 3. I don't know if there's, like the Surgeon General warning on the side. They're looking at it and go, oh, Surgeon General says 3. If a doctor asks you, say 3 cigarettes, right? Yeah, right. Okay. No, that's not necessarily the case. So you walk in, you open the door, and I'm sure Dr. McAlister can attest to this as you as well. You smell the waft of the cigarette coming out of there, right? And you're like, wow, is that Chanel or is that Marlboro, right? And so you're like, okay, you come in, you ask him how many cigarettes you smoke. I smoke 3 a day. Okay, well, you're lying, right? Instantly, I'm thinking if we're having surgery, this is going to dehiss, osteomyelitis, you go down the worst path, right? So I'm going to utilize something, and I'm straight up forward with them. I say, listen, due to this factor, this factor, this factor, I have to use adjunctive therapy to make sure we have the optimal fusion across. And patients get that, okay? Prelapse normal limits. I get some prelabs on these patients that I feel as though they're poor surgical candidates in terms of healing. And she had a Tmt Fusion on the other side that took forever to fuse. And she wanted the same procedure on the left side. So next slide, please. So you can see here, not too bad. There's some sclerosis. Got that navicular looks kind of whitish a little bit there. Okay. She's got a little fault. She's got a little cyst there. Okay. Not too bad. And quite honestly, I tried orthotics. I tried injections. I tried NSAIDs. I tried bracing. Nothing seemed to be satisfactory for her. So I was like, okay, well, we got to go down this route. So next slide, please. So isolated Tmt Fusion. This is immediate post-op. I apologize about the quality of our x-rays. X-ray group is not so hot in terms of trying to get it, but with the cast. But you can see, use a plate and screws and staple on there, and pretty good fusion across there. Next slide. In 4 weeks, she's walking on it. Okay. You can see there's good consolidation across there. I haven't seen her back yet. This is a recent film here too. So she's walking on it. She's happy. and anything that I can do. And if one thing that I can stress throughout all presentations, and I'm sure Dr. McAlister's got some great examples too as well, is utilize something that is going to be the best for those patients to get these things healed. It's funny how these patients seem to want to almost do things to jeopardize a good result. And that's why I tell patients, whoever are coming in for a pint of skin or a pound of skin, I say, listen, anything can happen in surgery. So I'm going to utilize something. And that's the one thing that I will not go back to any type of bone graft. Number one, now it's never spit out. Number two, the handleability. I know that's not a word, but I'm going to say it tonight. It's very easy to handle. In fact, I had a couple students from local colleges were able to observe, and I shot some in their hand, and I'm like, wow, this feels pretty cool, right? That's what students say. But I had to give them opportunity to feel that. It probably cost the patient $700, but I'm just kidding. But one of those things where it's so easy to use. I utilize that as a backfill. I utilize the primary fusion. I'll squirt it within the joint surfaces themselves. It's just very easy to use. And I think it's not going to gum up on you when you try to put it in there. And the applicator is very, very easy to use and squirts right in the area. So I know you probably have some questions regarding my case studies, but at this point, I'll turn it over to Dr. McAlister, and I'm sure he's got some great cases too as well. And I want to thank Paul for you inviting me this evening, and I'll stick around after McAlister if there's any other questions. So
Thank you, Dr. Yeager. Appreciate it. And
no problem. There's my family. This is why we get up in the morning, you guys, and this is what it's all about.
What a nice looking family you got.
Thanks.
Okay, thank you again. And now I'd like to introduce Dr. Jeffrey Mcallister. Dr. McAlister is the founder and CEO of the Phoenix Foot and Ankle Institute in Scottsdale, Arizona. Previously, he worked for CORE in Phoenix, Arizona, and was the co-director of the Foot and Ankle Fellowship there. Dr. McAlister got his doctorate in podiatric medicine from Temple University in Philadelphia, and served as a chief resident under Dr. Steinberg, Attinger, and Kim at the Limb Salvage Service at Georgetown University Hospital in Washington, D.C., followed by being chief of podiatric surgical resident at Innova Podiatric Surgery Residency Program in Falls Church, Virginia, for rear foot and ankle surgical reconstruction. In addition, Dr. McAlister did an advanced fellowship in orthopedic foot and ankle under Doctors Heyer, Burlett, Philbin, and Lee in Westerville, Ohio. Dr. McAlister also has published, been author of numerous peer-reviewed publications, written numerous textbook chapters that are published, and also has done a number of studies and continues to do studies to advance his chosen profession, which is foot and ankle surgery. So I'd like to turn it over to Dr. McAlister now for his presentation.
Thanks, guys. Can you hear me?
Yeah.
Good. I think foot and ankle chose me, actually. I wanted to be a dentist for a long time, and then I went to the other end. But thanks for having me on. This is our days in ORs 3 and 4, Monday, Wednesday, Friday, or whatever your chosen days are always an adventure. And as was described, we always try to seek out new opportunities for success. And this has been one of those for me. And I wanted to kind of share that and how my experience has been with it, but also other items that have come and gone, as David said, through time. And we're starting to see that some things are starting to stick, no pun intended. So we have a 32-year-old male. So what I want to do is kind of highlight a couple things. One is David brought up some opportunities for use in, I would call them critical patients, maybe patients that are smokers, obese, etc. I'm going to kind of put a little trauma spin on it, and then I will put in the kind of everyday utility. And then I want to talk a little bit about some pearls with rep usage and the reps that are on, like how can I sell this? How can I make this, sexy again and bring back this into the OR? Someone that's been using something else for a while. Let's talk about a new product. So we'll go in that order pretty much. So this is a Phoenix dirt bike, a 32-year-old male, way on the west side of town where I think Bill Gates just bought like 100 acres or 100 million acres or something crazy. But basically he's riding his dirt bike out there in the middle of nowhere. But he has a Harley at home, and he just got home from his motocross activity and decided to go riding his Harley in his cul-de-sac barefoot for whatever reason. And it got out from underneath him. So that happened a couple of days ago. And he shows up after being seen in urgent care and splinted in the whole 9 yards. They deemed it not necessary for him to go to a level 1 trauma center or whatnot. But he showed up. He's relatively healthy, young guy. He works at a kind of Brakes Plus or whatever, and does the standard recreational marijuana, which is going to show up on every slide nowadays. And no obvious fracture blisters or, it was a closed injury. And it was all splinted up. Go ahead. So now I'm kind of thinking, what do we got going on here? This looks bad. This is not a standard private practice kind of injury. What do we do? So we have a comminuted navicular tarsal dislocation. I mean, there's like 10 ICD-10s in here. So we have a tarsal dislocation. We have a impacted talonavicular joint. We have a stable Liz Frank. We have a calcaneal fracture that you just saw on the CT scan. And we need a plan. So this is where kind of the rep pops into my head. You're sitting in the room talking to Charles or whatever, and you're saying, what am I going to need for this case? And my head goes through hardware, and then typically extra or other, and bone graft is at the end of that. Not in any way of importance. So, or priority. So the key here is, what do we do with a dusted navicular? And how can I get this 32-year-old relatively healthy guy back on his motorbike fast and, do that in a steadfast manner? So go ahead. So the plan basically was fix calc, get that stabilized, then go dorsal medial and approach the TN dislocation and tarsal dislocation and navicular fracture. So we did it in that order. What we actually had to do was refashion a large portion of his navicular. So the medial pole was dusted. So that all came out. Then I said, what am I going to use to pack all these little voids? And how can I get good bony apposition between femoral head and the remaining aspect of the navicular and cuneiforms and talus and everything else. So obviously we're talking about stable fixation, and this isn't a trauma lecture for Midwest or PI or whatnot, but damage control and getting this calc stabilized was our first priority. And then go to the next slide, and then stabilizing his TN joint. So here's where I utilized putty. So that's been my priority my number one product of the two is the putty. And I'll start with the 2, and then if I need to, I'll slap in another 2. I would say for most cases, I'm using the 2.5. So and there's 2 different sizes, right? The 2.5 and the 5 for in Phoenix. So for now, so after we got our calc stabilized, then we moved on to our TN joint. At this juncture, we said, you know what, this tarsal dislocation is not anywhere near just a standard ORAF. We're going to have to fuse this bad boy because there is nothing left. So it kind of sucks, 32-year-old with a hindfoot fusion, but it is what it is. And this can get him back to working at Brakes Plus and maybe riding a motocross. I gave him 6 months, but I think he was on the short end of that. So this was immediately kind of leaving the OR. We felt good about it. We stabilized his navicular. We spackled our nanobone basically on either side of the iliac crest, and we did not tuck it in the calc fracture or anything like that. We were all lateral, and we didn't utilize it for the calc fracture, but mainly this, as Dr. Yeager said, this TN joint that has a high propensity to go onto a non-union. How can we save this guy's foot? So next slide. Stabilize it with kind of a neutral dorsal locking plate and good bicortical purchase. We did not, kind of in order, just is stepwise, I guess you could say. So what we did first was calc, obviously. Then we built out and refashioned a new navicular is kind of what we did. So after we cut the femoral head on the back table, we spackled both sides of it with our Nanobone, and then fixated it to the lateral portion of the navicular there. You can see that. So rebuilding that navicular and then affixing that to the talus. So that was our RAF midfoot dislocation, navicular fracture, and TN joint all kind of combined. So kind of like you would almost like a Liz Frank fracture dislocation. You go in kind of planning, are we going to fix this or fuse this? How bad are the joints? We get a CT scan, and now we're looking at a dusted midfoot that we need to fuse. So that was the general concept in terms of consenting and things like that, which are above and beyond this talk probably. But what's to note is that his NC joint was still intact. I was trying to save as much as possible. And that was what we could salvage out of the distal lateral pole of the navicular. So what I've found post-operatively, I do use incisional vacs, just putting that out there. But what I do find is reduced edema compared to other bone graft products that we've used in the past in my OR. Reduced drainage, which is super cool. We're not seeing a ton of like drainage from these products. And the incisions are well healed at this point. I see people back at 10 days and then take off their incisional vac, especially for a case like this, and then get him into a cam boot. He was non-weight bearing for 10 weeks. I really held him down to the fire and said, hey man, if you want to get on that dirt bike again, you are going to have to like chill out. So after about 8 weeks, we started physical therapy. We did not utilize a bone stem, and I found that I've barely have to use bone stems at this point because of what we're using here and talking about today. So that's another kind of added little pearl that we could talk about as a rep going into a doctor's office. So next slide. So that was we'll call him Charles. He did great. So now we have a 68-year-old female, left ankle pain, the typical, we don't put it in our charts anymore, but flat feet. She's failed conservative treatment and she's moving on to the surgical conversation, and she's exhausted everything in terms of amnio and all the stem cell shots she could purchase. That has gone to the wayside. This is a mechanical structural deformity. I would say her BMI is in the range of 32. She's relatively healthy. She doesn't smoke. It's kind of standard 68-year-old Phoenician active person that walks the dog and wears her Hokas every day and is trying to maintain a healthy lifestyle, but she just can't do it anymore. She can't keep up with her friends. Next slide. And she needs to move on to the next option. So you can see here, kind of going from left to right. Naturally, your eyes go left to right. I typically will, if there's a bunion present, my staff will automatically get a kind of 4-foot view standard series, included the sesamoid axial. So you can see that those arthritic changes to the first metatarsal sesamoid joint. We would call this like a grade 4 or so met sesamoid joint arthritic changes. And that's a whole nother topic. But obviously checking our radiographic our ankle films, confirming that our ankle is not in valgus, right? Often we miss that and we don't control it, and we avoid looking at the ankle from the front, not just the side. So lateral view, this wasn't too impressive radiographically, but clinically it's what you would imagine. You can see on the AP foot there, her previous navicular fractures or os tibialis externum or whatever the kids are calling it these days, is severely arthritic. And so she is in a ton of pain. A lot of, you can see her subfibular impingement on the AP ankle view. And so this is that patient where we're talking about selective arthrodesis versus how bad is the subtalar joint? Are we doing a calcosteotomy versus a Illinois specialty infusion? And that was for you, Dr. Yeager.
Thanks,
and
brother.
so, yeah. And so, But in this patient, 68, high BMI, this is a selective arthrodesis or kind of a medial double type approach for me. Next slide. And what I've been leaning on recently is really focusing on stabilizing that medial column. And the quickest, easiest, simplest way to do it is a first MTP fusion that stabilizes that FHL, and you're able to bring down that first MTP well. So after we did our spackle job intraoperatively, this case was about 5 cc's. We were able to get in a ton. You can see it right there. So she's about 3.5-ish so, or post-op, 3.5 months post-op here in this image. She's in her ASO, walking in her shoe, getting back to walking Frankie, the Bichon Frise, and she's super happy. So this is just another utility, another option for you to utilize it on these type of selective arthrodeses. Once you've repositioned that calcaneus, you do typically have a large void in your sinus tarsi area and posterior subtalar joint. So being able to fill that cavity with a good amount of the nanobone, and what I like about it is the texture, as the Dr. Yeager mentioned. The texture is super, I'll call it fun. It's nice. You're able to handle it and put it where you want it, and it stays there. So that amorphous silica gel, that ASG, is very, very nice handling capabilities or qualities. And that's probably my number one, besides it actually working, is I guess my number 2, Pearl. Next. She's doing great. So another one. So this is, we'll just call her Laura, 57-year-old female, painful forefoot. And, but she does have some discomfort underneath the second toe, but, you know, it's mainly the big toe. So what are we doing? Let's look at some x-rays, and let's see what we can do for this relatively healthy non-smoker, again, active hiker, loves to hike camelback, but she wants to get back to her tennis game. So next slide. So again, this is this patient that we often see, as Dr. Yeager mentioned, the second opinions. Her bunion was done umpteen years ago, but she didn't follow up after her 3-month follow-up when they said go away. And she ended up just kind of floating off into the sunset. And I'm sure she's been on many vacations and walked on many beaches and not have had pain, but she comes into the office with continued second MTP pain. So that's what we see in the office, right? We see those patients that come in with pain underneath the second MTP and some metatarsalgia type pain, but then you take your radiographs and your eyes get all big and you try to control the conversation and just kind of steer them in the right direction. And so we're talking about a first MTP fusion. I don't think most people would attempt a revision 15-year-old osteotomy and try to salvage the joint, even though it looks as though there's still some cartilage there. She had a negative grind test, but I don't think I could let her off the OR table with an unstable first MTP. So in my hands, this is a no-brainer. This is kind of what I was referring to at the beginning of the lecture. You know, this is where I would typically use a perfect spackle and dress that first MTP perfectly, fill the voids, and make it work. So next slide. So first MTP fusion, standard screw plate construct. This is about 6-8 weeks out or so. And she's, you know, I'm able to transition patients into a post-op shoe faster than I have normally. And that's always great. So again, I like the early rehab thing too. My MTP fusions, I think it's honestly interesting how we as a profession kind of dance around with our weight bearing protocol. You know, everybody is just, it's not standard. And so there's multiple studies on MTP fusion, midfoot fusion, et cetera. But I move people fast too. I have them weight bearing at 10 days and they're out of a cam walker boot and into a post-op shoe right between 4 and 6. I'm having a hard time like keeping them down. So it's fun. People are doing great. And that's another success story. Next. So LR, this is another one where It's a standard OR2 11 a.m. You're running through your cases. We have first TMT pain, very active bunion. And so this isn't just for the revision high BMI smokers. It can be utilized in your regular everyday cases too. Next. Standard bunion patient, and our sesamoid axial view again shows no significant arthritic changes. So we're looking to do a realignment or a reconstruction of her medial column or spine of the foot. Appropriate hindfoot to forefoot relationship. So we're not thinking that we have to do anything else. And we're moving on to a first TMT fusion. So next. So I typically utilize a cut guide system that allows me to kind of spin it, if you will. And so what we're able to do here, you can see that sesamoid axial, we're able to realign that sesamoid axial well. This is at about 6-8 weeks out or so. And still these patients are, I mean, she actually came in a tennis shoe at like 3 weeks. I said, please do me a favor. Please at least get into this post-op shoe or something. She was doing phenomenal. I don't know whether it was the Nanobone or whether it was her just being a crazy athlete, but something had to meet in the middle. So she was able to get realigned well. We filled any voids. If there is any plantar gapping or whatever you run into, you can always fill those voids with some sticky Nanobone, and you don't have to worry about it running away from you, as Dr. Yeager said. So another success story, and she is doing well. Next. So how I would kind of spin this as I kind of go into a doctor's office that's, that they are a heavy right medical user, that they are a autograft user or whatever the case may be. This stuff works. It's proven. I've seen it with my own eyes. And this is another opportunity for, as Dr. Yeager was describing, kind of a high risk patient where you can spackle it onto these metallic implants. This is a custom TTC fusion that we did yesterday. And so he's not fully healed yet, but almost. And so, but we know that HA is more natural. Who you can't argue against more natural. And the handling characteristics are awesome. So those are two things that you need to show your, if you are a rep on this call or distributor or whatnot, you need to bring it into the office, squeeze it in their hand, tell them to put a glove on first so it feels more like you are in the OR, and or bring some gloves from the OR so they can feel what it would be, what it would be like in the OR. And you typically don't need autograph with this, as he said or was stated. And I did mix a little BMA here just to make myself feel better, but I do pull BMA on most cases. I hate to admit it, but again, all natural, and you can stuff it into little crevices. And please try it out, because I think the handling characteristics are above and beyond. So some cool cases, and I hope you don't just focus on the obvious kind of non-unions and stuff. Those are great cases, but please think about your obvious cases too. We want to keep those MTP fusion non-union rates down. And as we are trying to mobilize and move these people faster, I think it is an easy way to continue that success story. Thanks for having me, guys. Any questions?
Thank you for the case presentations. I really appreciate it. Just quickly as a summary, we're asked a lot because there's so many different options out there now for bone graft substitute products. There's literally hundreds of different products that physicians get to choose from. And they're bombarded a lot of times on almost a daily basis of some new this or that or the other thing. Well, you kind of have to then drill down into what is really the big deal about Nanobone, what really truly makes it different and unique. And for your purposes, Dr. Yeager and McAlister, the handling, that's what you see and touch. That's your first impression. You can't see the science. You see the product in your hand and you say, hey, I like the way this handles. That's a good starting point. If it didn't handle well, you'd be less interested in it. So at least we kind of can jump over that hurdle pretty much right away. But selling Nanobone and sort of understanding Nanobone is almost like understanding a pharmaceutical, because it's a concept cell. The real mechanism of action, the real reason a product like ours works the way it does is hidden in the science within the product itself. And you guys don't see that. You touch what you touch, but it's kind of like you might as well, I could put a pill in your hand and or you could put a pill in one of your patient's hand and they swallow it and it does something, or it's supposed to. You don't know how, but it does. For our purposes, drilling down into some of the basics with regards to what makes Nanobone unique, different, and quite frankly, better starts with the foundation of the product, which is this bioidentical HA, 50 nanometers by 3 nanometers. We're the only company in the world that does that. So that product didn't exist before one of our founders over in Germany, an applied physicist, figured out that that's what he needed to have a successful product, a sort of a new generation of synthetic. It needed to start with the right size and shape of HA that happens to be bioidentical. So he produced a synthesis method where we actually create that. We're the only company in the world that does that, building HA 50 nanometers by 3 nanometers. The next step then is to put it into a form that you can actually work with. That's combining it with this amorphous silica gel that is essentially like a proxy for type 1 collagen. In bone, you have your nanocrystalline particles of HA effectively suspended in type 1 collagen. That's your bone matrix. We don't use type 1 collagen. We use amorphous silica gel because it has some properties to it that make the product work better. It clots quicker. It has this negative charge. It's a placeholder that then goes through this matrix change, allowing all the proteins and so forth coming in. The other very interesting thing about Nanobone is a gram of our material has an enormous amount of surface area, and a gram is a little bit less than a cc. A gram of Nanobone has 208 square meters of surface area, which is about the size of a tennis court. So there is this enormous amount of real estate that allows for binding of all the proteins that you need to grow bone in the first place. This is really kind of an interesting feature of the product, is because you've got these tiny little particles, it's all surface area and very little volume. So you've got this just enormous amount of surface area that allows the different proteins to stay put. And then moving on from there, we get this very rapid onset of new bone growth. Essentially what we're trying to do is get the body to do what it needs to do wherever you place it. If you place it in a cortical site, it'll turn to cortex. If you place it in a cortical cancellous site, it'll turn into cortex and cancellous. It'll turn into the type of bone that is patient dependent and site specific. So that's another interesting feature to the product. And as I mentioned before, that osteogenic matrix is something that occurs, within 14 days of implantation. In clinical cases, as you've seen here with the presentations that our presenters have done earlier, we get the material will convert all the way to natural autologous bone in quite frankly, less than 6 months. We've got evidence of full clinical and radiographical healing in as little as 8 weeks, and that's on some pretty major cases with a lot of bone graft. Other products don't make those kind of claims. So it really sets us apart from the rest of the sort of noise that's out there and all this slew of products that are on the market right now. We really do have a patented, chemically unique, very interesting sort of next generation synthetic bone graft substitute. So
awesome.
Anyway, what I'll do now is I'm going to open it up for questions and answers.
Can you see?
And so what I'd like everybody to do, if you have a question or a question, I guess we have the answers. But if you have a question, I'll go ahead and read them. Just go ahead in the question section, type in a question, and we'll go ahead and read them and then answer them. But I've got a question from Ryan here that says, Dr. Yeager, are you able to track your bone regeneration given synthetics can block the view of fusion over time? And I think he's talking about sort of more dense types of synthetics.
Yeah, actually, I've never had to really do that because I'm getting so incredible fusion at such an early time. So I'm very satisfied with the product in terms of that. I really have never had to do that. I hate to sound like too much of a commercial, but like Dr. McAlister alluded to, I mean, this stuff is getting results quicker than any other product that I've used so far. So no, I haven't.
Okay. I'll ask a question real quick of both of you. In your clinical practice over the course of the years that you've been practicing, can you give us a little rundown of the other bone graft products that you've tried and what your experience has been with some of the different products that are out there?
Yeah, Matt Healy, can you hear me?
Yeah.
Can you hear me?
We can hear you, Jeff.
Oh, okay.
Yeah, he
Matt,
can't answer, but he can hear you.
Okay. Matt Healy had a question that kind of similar. Can you mix it with antique? I think maybe that was meant to say augment. I'm not really sure.
Probably augment.
Probably. So if you want to know your CFO really well, you can mix it with a lot of different things. Oh, antibiotic. Okay. Matt says, Mr. Healy says, can you mix it with antibiotic? I'll let you answer that, Rod.
It's not specifically indicated to be mixed with antibiotic. That's a separate series of studies that have to be done to say that you can mix it. Physically, can you mix stuff into it? Yeah, and have other physicians mixed in vancomycin powder or some other types of things into Nanobone? Sure. I can't attest to the outcomes or the effect, as unless you do controlled studies, you just don't really get the science out of it. Physically, can you put those two components together? Sure. Does it have the effect you're looking for? Quite frankly, we don't know.
And honestly, if you're trying to do a fusion as you are placing an antibiotic in, then why are you doing that? Are you assuming it's infected and you're trying to, do a fusion at the same time? I'm not really sure why you would do that. It's not stimulant. It's not cerament. It doesn't serve that purpose. So I think we have to kind of like strategically separate those. But if you're doing it as a prophylactic kind of thing that's off label, I would assume, and it is not a normal foot and ankle procedure to be doing, in my opinion. But so my experience in the realm of bone grafts has been, I've done the standard surgery center BMA, not BMA, DBM. I don't think it works very well. It's cheap. It's cheap feeling. It's like your Target shirt versus your shirt that you would buy at Lululemon. And I don't think that it has as much osteogenic potential. And sure, it goes in and it maybe stays, but I don't think it has the ability to create bone like HA. I've had experience with Augment. I've used Augment for multiple things, ankle fusions, etc. As we all know, there's codes and things for it, but I think that it's different. I think that it's more synthetic than this. I don't think I don't like the granules that are, it's more particulate. So I think that can be a conversation. So it's handleability, as Dr. Yeager said, is different, and it's often mixed with other things. So then it kind of says, well, why are you mixing with why are you having to mix it with other things? So I've played with Augment, the DBM, what else is there? Infuse, obviously. I think we've all played with Infuse. We know that it's super expensive and only indicated in tibial fractures and spine. And so that's typically, anytime you use that, it's going to be off label. So I usually, kind of steer clear from it and let my patients know if I'm ever going to use that, it would be completely off label. And, but now that these smarter technologies are coming out, I don't think we need to be reaching for that anymore. And then what else is there? So
any experience with stem cell products?
Name one.
Trinity, Elite.
Actually, I don't. In residency a little bit, but obviously that's not real life. And no, I would say Yeager.
Yeah, no. Yeah, and that's cost prohibitive, to be honest with you. And when you asked that question, Paul, I just kept spitting out these on my, I got a little piece of paper here, all these adjectives regarding some of the crappy material that I've used, you've got these, and it is what it is. It crumbles, it spits out, it's not, doesn't stay where you want it to stay. I've actually been able to irrigate over the Nanobone, which is huge for me. And going back to, utilization of the antibiotic in it, I definitely wouldn't do that, because I agree with you, Jeff. What are we using it for? So I don't want to limit the ability of this product to do what it's supposed to do. And some of the things that are out there in the market, the reps do a very good job and coached very well. I think this product sells itself, and I agree with you 100%, Jeff. Is get them to touch it and feel it, and it's being able to place it where you want to put it, and it doesn't flush away, I think is a huge advantage of this product. And so I've utilized everything on the market, and being in the hospital, they're always cost prohibitive in terms of what they want to use and what we can and can't use. And I tell them, and I will go to bat for this, as I'm utilizing this and nothing else. So I like it. It's easy to use, it works, and it's predictable.
Yeah, that's actually one of the arguments that we've been able to make, is that if you have been using maybe combinations of multiple products, you don't need to do that anymore with this product. I know that habits take time to adjust. And I understand, Dr. McAlister, that you have a comfort level with BMAC. And that's fairly routine when we're having physicians that are switching to fully using Nanobone. It takes some time to have them convince themselves that they get out of our product clinically what the reps promise that they're going to get. Every physician really sells himself on a product based on their own personal experience with it, and their confidence level then develops over time, and they become committed to using a product based on how their patients are doing, quite frankly. And those are steps that physicians have to go through, I think, basically every single time. What we've seen, the product's been on the market now for 3 years or so. And most of the surgeries that have been done sort of historically have been in spine cases. And now we're bridging into some of these other areas that we feel are really nice markets for us to go into, foot and ankle obviously included. We've done quite a bit of stuff in trauma and some orthopedic oncology, mostly spine. One of the interesting things that we found is that physicians that jumped on board early back 3 years ago, to this day, continue to use the product. We don't really tend to lose guys off, sort of wandering off because they have found that they're not getting a good result. And that's really what sort of will drive physicians' decision-making. A lot of times they'll start using a product, and maybe they'll get 6 months to a year into the use of a product, and then they'll become dissatisfied, maybe just somewhat with their clinical outcome, and say, well, I'll try something different now. That has not happened with our product. It's really a testament to where the rubber meets the road, which is good clinical outcome. Yep. So, we're very, very pleased with that. And we have been able to keep the surgeons that we started working with even 3 years ago, they continue to use it to this day. So that's kind of been our progression.
The nice thing that I see is, if you're doing a myriad of different types of cases, like your first case is a Tmt Fusion, your next case is a revision TTC thing that I was showing. I mean, you can utilize it on different types of cases. And for most 90% of foot and ankle cases, you don't need more than 5 cc's of anything. So, when companies try to say, hey, our only volumes are like 1 for really hand navicular scaphoid kind of fractures, 1 cc, and then the 3s. And then all of a sudden it's like, okay, our next size here, doctor, you're scrubbed in already. And the circulator goes out of the room, and then she comes back with a like 30 cc jug of whatever, chips or something, some dead bone. And it's you're like, okay, I guess I'm supposed to use 30 cc's in this TN joint that Dr. Yeager's doing. This is great. And half of it goes in the trash. So the volume, the thought process between the 2.5 and the 5 is right on with foot and ankle. And I would even contest, the 1 cc may not be a bad option for some guys, or maybe surgery center type environments later down the road. And then I will say that I do, on especially big TTC fusions or something, I will, for volume's sake, I will mix some autograft with it, just to span the whole area. Or if I have like a dusted calc fracture that I'm doing a subtalar joint fusion on, I want to make sure the entire area is covered. But I do think the HA is very natural, and it mixes very well with autograft too. So that's a good kind of selling point for guys that just use autograft and they're stuck on it and they don't want to use any synthetic at all. This is a nice little bridge from the cheap stuff that they might get out of the calc to, from a more volume standpoint. If they are doing those bigger cases, you can add this in to jumpstart your fusion and reduce edema and all the good stuff, and still make them feel comfortable, at least that they're able to get their autograft in 20902 and however else they think about it, if you will. So.
We're down to running out of time. There's one quick question I'll answer before we adjourn, because we're right at 6 o'clock now, California time anyway. The last question on our list is it osteoinductive? Well, that's actually an FDA regulated claim that you have to go and ask for. We've got animal data that suggests that the product is osteoinductive. In different sheep studies, we've shown bone growth in ectopic sites, which is the definition of osteoinductivity. We have data that from these 4 studies that we've done that we feel is something we could present to the FDA and ask for the labeling, but we haven't done that yet. So the answer is no, we don't claim osteoinductivity in the United States. Interestingly, in Europe and in other countries in the world, Nanobone does claim osteoinductivity. So I mean, as a joke, I've had physicians ask me, is it osteoinductive? And I say, well, it is in Europe and Australia, so it's, we can't make that claim here in the US. But anyway, I want to thank you both, and I want to thank all of the attendees today for joining us. I really appreciate you taking time out of your schedules to listen to the presentation and participate. And I once again want to thank Dr. McAlister and Dr. Yeager for joining us and participating. I think we had a really good webinar today, and I really appreciate your time. Thank you, everybody.
Take care.
Okay, take care. Good night.
Stay safe.